Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the HEMONG podcast. We're coming at you from Loyola University Medical Center. I'm Rodak.
I'm Vivek.
I'm Dan.
And in today's episode, we continue on our sickle cell disease journey, this time talking all about sickle cell disease complications, things that may develop in our patients long term with sickle cell disease, and things that we need to look out for, especially in the outpatient setting.
Excited to get into this one. It's really useful and not something that you learn a lot about in internal medicine residency, and not until you really get into fellowship. And if you don't see a lot of these patients, it's always good to refresh yourself on these things, because the off chance that you do run across one of these patients one day, you need to know some of this stuff.
Yeah, and you know, there's so many different complications. I'm glad that we were able to try and kind of consolidate some of that into a single overview. So this is going to be a great show.
All right, guys, let's go ahead and roll that episode. So at the time that we are recording this, one of the hot topics in TV land right now is this Dallas Cowboys cheerleader docuseries on Netflix. And Vivek is on the edge of his seat wanting to give us his thoughts about this. So I'm just going to go ahead and turn it over to Vivek to shed some light on his perspective on this story.
This is definitely the most important part about this episode. So the Dallas Cowboys cheerleading documentary, I have to give it a 10 out of 10. You know, that doesn't always happen, but I'm going to give it a 10 out of 10. The women who are trying out for this, they're incredible. It's like the most elite dancers and cheerleaders in the country who come down and do all these tryouts. It's actually insane. Highly recommend. Very interesting documentary. They're way underpaid, and I don't like that. They definitely need to get paid a lot more. They are so talented. It's really fascinating. I didn't really know what went into that process until I watched it.
Yeah, you know, as someone who I think for obvious reasons has never really paid attention to the cheerleaders when I watch football, I may have to start watching and seeing what they're actually doing.
I think I'm gonna have to check this out too. Again, you are the nth person that has mentioned this to me, and everybody has said overwhelmingly has had positive things to say about the show. So definitely something I need to add onto my list, but I do need to finish The Bear first. I'm really far behind. So that'll be after I finish the season of The Bear. But guys, today we are continuing on our sickle cell disease journey, this time talking about complications. And these are not, the complications that we tend to think of, especially for those of us that have only seen patients with sickle cell disease in the hospital. These are complications that we may see if we were to have an outpatient sickle cell disease clinic and take care of these patients in a more longitudinal fashion. So I have a case just to start off our discussion today, and then we'll kind of use this as a launching point to then have further discussions about this topic. So this is a 23-year-old male with a past medical history of sickle cell disease that was complicated by several admissions in his childhood for vaso-occlusive crises, who presents to your clinic as a new patient to transition care from pediatrics to adult medicine. Thankfully, his parents do not believe that the patient has ever had acute chest or strokes in childhood, and so they inquire about what long-term care looks like for their son, given the complications that can arise from sickle cell disease. So, in this series so far, in our primer episode, we talked all about the fundamentals of sickle cell disease. We talked about the Mendelian inheritance pattern, what causes deoxygenated hemoglobin to polymerize and deform cells. We talked about the downstream consequences relating to the fact that blood goes everywhere, and that is why we have all these issues. We provided a breakdown of electrophoresis patterns that we use for diagnosis. We also talked about, some more complicated compound heterozygotes that may arise that can also present. So really a lot of really important information. Definitely go back and take a listen to that episode if you haven't done so already. But, in this case, we have a patient who's presenting to establish care. And so what are the current screening guidelines for patients, especially adult patients with sickle cell disease, that we need to be aware of in the outpatient setting?
Well, like you said, the blood goes everywhere. So the problems that sickle cell disease causes can be in any organ system. There's a great graphic in a Nature Primer publication from 2018 that we'll have a link to in our show notes that can kind of demonstrate some of these different organ systems and how they're involved. But throughout the course of this episode, we're going to go through a number of the different complications over the course of this episode. But because there are so many and so many different organ systems, there are some guidelines that help clinicians screen patients with sickle cell disease for complications. And so experts recommend that in addition to your regular H&P history and physical exams yearly, patients with sickle cell disease should also undergo screening with a CBC and reticulocyte count, have their liver function tests assessed, check their creatinine, an annual serum ferritin in patients with multiple transfusions in their history, and that's a majority of patients with sickle cell disease. Pulse oximetry should be checked, and an ophthalmologist should perform a formal retinal exam because of the risk of retinopathy. Obtaining these studies sort of over the long term so that they can be trended is really important, so that when we do see complications arise or when patients are beginning to have symptoms, we'll have a baseline for comparison. And similarly, when patients transition their care to new centers as they move, as their life happens, we'll need to make sure that those records travel with them so that their new providers have a good grounding in what their disease looks like.
That's all really, really important, Dan. And as you're saying, these are labs that we should at least be checking once a year just to have a good baseline. So should complications arise, we have something to compare to when patients present to the hospital. And, as I mentioned in the beginning, a lot of physicians don't take care of patients with sickle cell disease in the outpatient setting. And unfortunately, their familiarity with this disease is when these patients are admitted to the hospital. And one of the chronic complications of sickle cell disease that manifests when patients are often seen in the hospital is going to be pain. So I guess my first question to you guys is, why is chronic pain such a common phenomenon? And as a follow-up to that, in the chronic setting, what can we do to help manage this pain?
That's a great question. And unfortunately for many providers, we're really seeing these patients in the acute hospital setting and don't have a lot of experience managing them in the chronic outpatient clinic setting. So the big thing is these patients with their sickle crises have infarcts in their bones. And that over time, recurrent infarcts in the bone areas, this can cause pretty severe altered neural pathways, and it can cause damage to some areas of the bones and some other areas, which we'll talk about, things like avascular necrosis. So that's a really, really tough thing for these sickle cell patients to deal with. And their altered neural pathways can exacerbate this pain. There are a lot of triggers for this pain. It can be infection. Sometimes it can be physical triggers. It can be dehydration. But it's also important to focus on the social determinants of health, things like depression and anxiety. These are things that can also trigger and worsen these chronic pain symptoms that these patients experience. And the goal here is to control the pain to allow our patients to live as normal functioning life as they possibly can, knowing that these acute pain flare-ups will occur, but let's do everything we can to minimize the chronic pain that they have had. One of the best studies that really discussed how common this is and really discusses how patients feel their pain is being managed was something called the Pisces study. So it was a longitudinal cohort study of over 300 patients with sickle cell disease, mainly who had received care in Virginia. And in the study, they required these patients to fill out daily diaries that evaluated health-related quality of life metrics. And that study really highlights that we need better resources to educate providers in managing the chronic pain that these patients experience. So we'll discuss pain management more in a future episode, but in general, a multimodal approach is recommended, and this includes NSAIDs and, when needed, opioids, antidepressants, and things like gabapentin, in addition to non-pharmacologic therapies, which are all very critically important. And when we think about chronic pain, one of the things that I mentioned earlier is that issue with avascular necrosis, patients who have this chronic hip pain issue. So can one of you elaborate on avascular necrosis a little bit more?
So as the name suggests, because sickle cells can cause occlusion of the small blood vessels, they also cause limited or impaired blood flow to the bones, which can result in bone necrosis, in addition to these marrow infarcts that you'd referenced. The most common site for avascular necrosis in patients is the hip, and it's estimated that about 20% of hospital admissions for pain are related to avascular necrosis. We call it AVN for short. Most commonly, like I said, it'll involve the hip, but it can also involve the shoulders, as well as the other joints like the knees, feet, or even the back. If there is concern for this, you start with an X-ray, which might show sort of sclerotic changes, arthritic changes, or in extreme cases, even collapse of the femoral head in the hip, for example. But in earlier manifestations of the disease, before some of these chronic changes have had time to evolve, an MRI might be a better bet, and it might be better able to pick up these subtle changes. At first, We focus on conservative management like multimodal pain control, physical therapy. But ultimately, if this progresses, joint replacement might be necessary. As you can imagine, if you're looking at a collapsed femoral head, that's not going to get better with just a little bit of strengthening of the muscles around. It just needs to be swapped out. It's obviously, that's a challenge too, right? Operative management in an area that already had poor blood flow is going to be difficult. You're going to have issues with wound healing and recovery, but it can be really an important procedure for folks in terms of getting function back in those limbs.
So I vividly remember early on in residency, I had met a patient with sickle cell disease, and I was shocked to see stroke listed in their past medical history. And after caring for countless patients with sickle cell since then, in the inpatient setting as a resident and as a fellow, I've been seeing this time and time again. And so it is very evident that stroke is more common than I thought in patients with sickle cell disease. And so I think the next thing that I think we should talk about is, why are patients with sickle cell disease so prone to develop strokes?
We really could have an entire episode to cover each of these complications and still have more to talk about. As you said in the intro to our first episode, Veronica, we could have a whole sickle cell podcast, and maybe we'll have a spinoff someday. I don't know, but for the time being, I'll take you through some of the highlights here. And I do want to point out that while we've made some advances in stroke prevention, at least compared to sort of the early days, there's still a lot of work to be done, especially resource-limited areas like sub-Saharan Africa and India, where more than 90% of the global population of folks with sickle cell disease are born. We don't really have great evidence-based methods that we can apply in these resource-limited areas to help prevent stroke. And it's estimated that 50% of children will have an overt or silent cerebral infarct by age 18. And so the incidence of overt strokes in hemoglobin SS disease is about 24%. And in hemoglobin SC, around 10% by age 45. So this is a really common and prevalent problem. In adults, strokes result as a combination of several different things. Basically, we can have these things set off just like a vaso-occlusive crisis with low oxygen content, either because of lower oxygen saturation or acute drops in hemoglobin, like during a vaso-occlusive crisis. There can be issues with underlying cerebral vasculopathy that compromises blood flow. And remember, this is sort of a positive feedback cycle that happens when sickling begins. So if that blood flow is already restricted and there's more deoxygenated blood, it sets up more sickling, which can cause further vaso-occlusion. And there are other cardiac risk factors as well that can predispose patients to this intracranial vascular disease, things like hypertension, diabetes, hyperlipidemia, all the normal things that you think of from your general practice. And in times of acute infection, that's another really high risk time. In any history of prior strokes, those blood vessels in the brain have been damaged and are changed. And that altered blood flow also can set people up for recurrent events. The other thing to think about is rapid increases in hemoglobin. So this is a little counterintuitive, right? You think, oh, higher hemoglobin, they should be better. In folks with a hemoglobinopathy, oftentimes pushing folks up higher than the 10 to 12 grams per deciliter range with either transfusions or with a phenomenon called autotransfusion that we'll talk about in our acute complications episode, it can really cause a dramatic increase in the viscosity of the blood. And the sort of critical microvasculature, like in the lungs and in the brain, really suffers from that dramatic and sudden increase in viscosity. Generally speaking, ischemic strokes are more common in patients less than 20 and greater than 30 years old, whereas hemorrhagic strokes, for whatever reason, are most common in the 20s, so from ages 20 to 29. An important caveat here is that while studies have found and identified these risk factors, to date, we still don't have any randomized controlled trials to help direct guidelines on primary or secondary stroke prevention in adults. Our best literature is really from the pediatric setting. And so can one of you take us through some of that evidence from the pediatric literature about how to guide management of strokes and stroke prevention in children?
I'll briefly summarize this. So I think the first thing to know is that in children, it's a lot easier to do ultrasound to actually measure velocities. And what was found was with transcranial Doppler ultrasound, it was found that for higher velocities, there was an increased risk of stroke. And so there was a lot of effort to be done to prevent stroke in patients who had increased velocities on their transcranial Dopplers. And there are 3 big trials. The first trial was called the STOP trial, and the STOP trial stood for stroke prevention trial in sickle cell anemia. So it's kind of a clever trial name. And what they did was they randomized 130 patients with a mean age of 8 who had no prior history of stroke but had elevated transcranial Doppler measurements to either standard of care or transfusions monthly targeting a hemoglobin S concentration of less than 30%. And what was found was that 11 children in the standard of care group had some form of either a cerebral infarction or intracranial hemorrhage, whereas only one in the transfusion group had one of those events happening. So it was a huge, huge difference. And that really led to transfusion support as a standard of care in these patients. Then came the follow-up trial STOP2, which basically asked, can we stop doing transfusions because we're iron overloading our patients? Is that safe to do? So in STOP2, after 30 months, so these are patients who had higher risk, elevated transcranial Doppler velocities, they had their transfusion support started. And after 30 months, if the Dopplers normalized, the question was, can we stop? If we stop early, are these patients going to do well? And it was found that actually the trial was terminated early because there was increased Doppler velocities found in those who stopped early. So this basically said that you have to keep going. You can't stop early. So the STOP trial said transfusions help. It prevents cerebral infarction and hemorrhage in those who had elevated transcranial Dopplers. The STOP2 trial says you can't stop early, even if you've normalized that velocity finding. And then lastly, we have the trial called TWITCH. And this is a really, really important trial. And what that trial asked really was, can we change transfusions to using hydroxyurea at maximal doses? So remember in our last episode where we talked about the fetal hemoglobin, hydroxyurea tries to drive up as much fetal hemoglobin as possible and also has other effects on the body as well. And it tends to drop down that hemoglobin S percentage. So the thought was, what if we up-titrated the hydrea as much as possible and got these kids off of transfusions? And it was found that children who were on chronic transfusion therapy after at least 12 months and then had a normal transcranial Doppler could be transitioned to hydrea at a maximally tolerated dose and still maintain the benefit that normally a chronic transfusion support would provide. So it basically said that if you switch to really high doses of hydroxyurea, you don't need to keep on transfusing these patients, and that's a safe way to manage them. So in children, there are guidelines. The hard part is, what do we do in adults? And really, there's not well-established guidelines. And really what we say is manage the comorbid conditions that Dan talked about, the hypertension, diabetes, and hyperlipidemia. Make sure that they're on hydrea. That's going to be very, very important to keep them on hydrea at maximal doses. And for some of these patients, if they have strokes, we do have to continue chronic transfusion support while balancing the iron overload issue. So that's really what we're dealing with here. So, chronic transfusions help those prevent strokes. If a patient's had a stroke, we continue it on in many cases. And if they're starting to get very iron overloaded, this switch to maximal hydrea dosing is a strategy that you can consider even in adults.
That was a great summary. It's easy to get lost in the literature sometimes, especially when it's technically kind of outside of our realm as a collection of pediatric studies. But I think that you did a great job breaking that down and making it sort of a really logical story. Beyond strokes, another big complication I've seen in patients is pulmonary hypertension. I have learned to fear pulmonary hypertension throughout the course of my internal medicine residency. And I know that it's a prominent issue in sickle cell disease. How do we work patients up for this, and how do we manage it when we find it?
So similar to patients without sickle cell disease, asking patients regularly about symptoms such as shortness of breath, dyspnea on exertion, excessive fatigue, exertional hypoxia, and chest pain should be things that we are routinely doing in our patients, especially during that annual history and physical that Dan mentioned we should be doing for all of our patients. And patients who endorse symptoms should be evaluated for pulmonary hypertension. The first thing that you can consider doing is an echocardiogram. This is because as many as 6 to 11% of patients with sickle cell disease are estimated to have pulmonary hypertension. And there was a large registry study of 533 patients that was conducted at the NIH that found that even in patients with moderate pulmonary hypertension, there was a mortality rate of 36%. So definitely something that we fear in the general population, but definitely a poor prognostic marker in patients with sickle cell disease. The buzzwords to remember is tricuspid regurgitant velocity, or TRV. which, as the name implies, uses the maximum velocity of the regurgitant jet flow across the tricuspid valve, which is found on echo. And then they use a mathematical equation that's way above my head to spit out a number. And a value greater than or equal to 2.5 meters per second predicts pulmonary hypertension and increased mortality. So this emphasizes why the echo is such a good starting point for our patients, because essentially not only will we learn whether or not they have these high TRVs greater than 2.5, but we can also learn about other changes in their heart, such as atrial or ventricular enlargement, hypertrophy, and things of that sort.
Yeah, Ronak, that's so important that you mentioned the echo and knowing that we're really looking at that tricuspid regurgitant velocity. Super, super important to keep that in mind as you're thinking about these patients and looking at their echo reports. So how would you manage that patient if they did have pulmonary hypertension, other than obviously referral to pulmonary?
Yeah, totally. And what's important to remember here is that the echo findings are not diagnostic of pulmonary hypertension. So if you do see these abnormalities on echo, you are going to make this referral, but the next step needs to be that they will need to get right heart cath performed in order to make the diagnosis. So your question about management, there's a great diagram that we'll put in our show notes that helps to break this down. But in addition to optimizing our patients from a pulmonary hypertension standpoint, which includes the use of things like vasodilators and fluid optimization that we would do in patients even without sickle cell disease, we have to also aggressively manage their underlying sickle cell disease. And so to date, there are no studies that investigate the role of Hydrea in patients with right heart cath confirmed pulmonary hypertension, but there was a case series of 5 adult patients who were homozygous for sickle cell disease. Actually, the authors had seen an improvement in their tricuspid regurgitant velocities and markers of hemolysis after Hydrea was titrated up to the maximum tolerated dose. And so the thought is that if we can decrease the number of these painful episodes and decrease the likelihood of acute chest happening, that we could also decrease hemolysis as well. And this can also help decrease the likelihood of progression to pulmonary hypertension. And chronic red blood cell transfusions may also be helpful here. This is something that you may see being done in clinical practice, but there's no peer-reviewed data to evaluate this. And so, of course, the million-dollar question is, should we be screening patients for pulmonary hypertension even in the absence of symptoms? And unfortunately, in the absence of data, there's no consistent guidelines on this.
Yeah, I think that's really important. And we're lucky at our center at Rouleau that we have pulmonary hypertension specialists, but that's not always the case. And these patients can be very difficult to manage when they start to get some of this end organ damage related to frequent sickling and like you said, frequent acute chest syndrome crises, things like that cause vascular remodeling and lead to all of these downstream consequences. So going along the theme of that, small vessels are getting impacted. So one could imagine that the kidneys are also impacted. Dan, can you tell us a little bit about chronic kidney disease and sickle cell?
You are correct. The kidneys are not spared from this microvascular damage. Believe it or not, most patients will actually start to develop sickle cell nephropathy starting at a really young age. It starts with glomerular hyperfiltration, which progresses to microalbuminuria in late childhood or early adulthood. And although this change develops really early, most patients will not progress any further. The numbers are variable with regard to incidence and prevalence of CKD in sickle cell disease. In fact, an older case control study from the 1990s suggested that about 4.2% of hemoglobin SS patients and 2.4% of hemoglobin SC patients had advanced renal disease, with a median age of onset at 23 and 49 years, respectively. We'll have a link to that study in our show notes. A follow-up study estimated that in hemoglobin SS, the rate was actually closer to 12% and had a median age of onset of 37 years. And in 2008, they looked again and found that advanced CKD was present in about 24% of sickle cell disease patients by the time they were 60 or older. And it ended up being the cause of death in 45% of patients who died beyond the age of 60 years. So it does seem like maybe as we're getting better for caring with patients with sickle cell disease and they're living longer and longer, we may end up seeing that chronic kidney disease can progress later on in life.
Yeah, that's really important. And you kind of mentioned that hyperfiltration. We see that there's lots of proteinuria and albumin in the urine, and we'll have a couple of links in our show notes that you can have things like nephrotic range proteinuria and things like that. And so it's important to screen our patients. And like most patients that a good nephrologist would talk about with diabetes causing proteinuria, ACE inhibitors are something that we think about in these patients. And there was a couple of other studies looking at the use of hydroxyurea. It's kind of this magic drug, and it really has changed the lives of a lot of our sickle cell patients. Rona, can you tell us a little bit about the data behind the use of hydroxyurea in patients who have chronic kidney disease?
Yeah, totally. And there's a great study name that's associated with this data. It's called the Baby Hug study. And this was a multi-center study looking at if hydroxyurea can be safely given to patients in infancy and if it influences renal function. And although hydroxyurea does not appear to impact the primary endpoint, patients treated with hydroxyurea achieved higher urine osmolarities and achieved smaller renal volumes compared to placebo-treated patients. A follow-up study known as the Hustle study demonstrated that patients from the ages of 18 to 23 years treated with hydroxyurea for at least 3 years also had better renal function. So it appears that sort of hydroxyurea continues to be this magic drug, and perhaps, again, maximally tolerated doses of hydroxyurea may also have beneficial impact on preserving renal function.
And that Hustle study, I think, really highlights the fact that we're preventing the damage from happening, right? Once a cat's out of the bag, many renal diseases and CKD, you can't really go back and reverse it. It's preventing this from happening. And that's the key thing with the hydroxyurea, and that Hustle study really shows that, and we'll link that into our show notes.
And I think it's also really interesting that they looked at urine osmolarity, and that's really important to draw out too. One of the big things that happens is the sort of inner part of the kidney that's responsible for concentrating the urine gets infarcted over the course of somebody's life. And seeing that result where patients are still able to concentrate their urine, I think it's a really sound physiologic evidence that this is doing what we want it to do.
Yeah, 100%. And next topic I wanted to discuss too, as we kind of get towards the end of this episode today, is iron overload, which I think is a critically important topic for these patients with sickle cell disease. So can we talk about a couple things with that? So we talked about the STOP trial saying that, hey, look, if there's elevated transcranial Dopplers, we do this chronic transfusion support, right? A lot of these patients are dipping their hemoglobins down below 7, 6, 5, and they need transfusion. So iron overload becomes very challenging. Can one of you talk a little bit about how often we screen these patients for ferritin and when we do that? When do we get things like MRIs for the liver? Can you just tell a little bit about how to manage these patients with sickle cell disease?
So when we're thinking about transfusional iron overload in sickle cell disease, just keep in mind this is an incredibly common problem. One study looking at 141 patients found that about a third of those patients had excess iron postmortem, evidence of tissue iron overload on postmortem examination. And 7% of deaths were thought to be linked to the effects of iron overload. This is not just, a biochemical abnormality. No, this is a real problem. And so the current recommendation is to check serum ferritin if patients have received multiple transfusions in their lifetime. So greater than 20 is usually the ballpark estimate. It is not hard to get to that in sickle cell disease. I honestly, if they've got greater than 10 lifetime, I'm thinking about it. And so we check ferritin every 3 months if they are sort of at risk with exposure to lots of transfusions in their life. And generally, if the ferritin is found to be greater than 1,000, and that's 1,000 nanograms per milliliter, then we use an MRI, a liver MRI, to measure liver iron content. We no longer have to go in and do a biopsy. We can actually use a specific MRI sequence, the T2 star MRI sequence, to make a measurement of iron in milligrams per gram. And that's milligrams of iron per gram of liver tissue. And so if the liver iron content is found on one of these scans to be greater than 15, then you also want to look and see if there's iron accumulation in the heart with a cardiac T2 star MRI. Ultimately, we want to use iron chelation therapy. Remember, we can't do therapeutic phlebotomy in a patient who's already anemic and is already having trouble making enough blood. So we have to use a chemical chelation therapy if the liver iron content is greater than 7, or if the ferritin is just consistently over 1,000. We have a nice article that we'll link in our show notes as well about this as a part of the ASH Review series in sickle cell. But just keep in mind that there is a therapy. Iron chelation works well. It can be difficult to tolerate, and there are some issues around chronic kidney disease that can make it difficult to pull off, but it's something that we do really have to be vigilant for.
Yeah, I think it's really helpful to keep that in mind, that liver iron content greater than 7 milligrams of iron per gram of liver tissue. It's easy to remember that 1,000 ferritin number. It's harder to remember that we're actually needing to get MRI. Let's not just get a ferritin, actually look for iron deposition in these tissues. It's really, really important to do that, particularly if you have any index suspicion, lots of transfusion burdens, unexplained LFT abnormalities, things like that. It's really, really important to consider that. So I wanted to throw it to Ronak to kind of wrap up today to talk about what are some other complications that these sickle cell patients have in the chronic setting.
I think what we've been highlighting over and over today is what we started out saying when the episode started. This is a disease that affects every single organ in the body, so even things that we haven't covered today may still be impacted, so it's important to be vigilant for all of this. Other things to pay attention to: patients with sickle cell disease are prone to leg ulcers, and this is due to poor circulation. So when you're doing your physical exam, make sure you're paying attention to whether or not there's a presence of ulcers. That is, of course, can get infected. And as Dan had mentioned with avascular necrosis, there's already poor wound healing that's going to happen because of poor blood flow. So you can see this vicious cycle that can arise if patients don't have these issues addressed. We mentioned retinopathy earlier in the episode. There's small blood vessels in the eyes. So annual visits to the ophthalmologist is crucial for our patients. And then we also briefly mentioned the multimodal approach to pain that we need to be addressing for these patients. And one of these factors are also psychosocial complications. Patients with uncontrolled sickle cell disease that have a lot of pain crises are unfortunately missing a lot of school and life events for hospital admissions. And from this can stem things like depression and anxiety. As we've mentioned before, depression and anxiety can also play into this process of creating painful episodes. And so it's important to also mention this as well. And then, the final thing that I will say, and of course, again, this is not an exhaustive list, but remember that venous thromboembolism is also a problem in patients with sickle cell disease. This is because of the biology that we discussed in our first episode about the complex sort of pro-inflammatory environment that's created when patients with sickle cell disease develop vaso-occlusive crises. And so paying attention and having a low index of suspicion to rule out thrombotic events, especially when patients have things like swelling or, concerns for a PE, we look into these things and don't dismiss these events because that could be really fatal for our patients. Guys, I think we covered a lot of information today. And listeners, as we mentioned throughout the episode, there's a lot of really fantastic resources with great figures and things that we'll include in our show notes. So definitely go and check those out. But as you can see here, these are complications that we don't often learn about or think about or even see unless you are part of a sickle cell program or rotate through the sickle cell clinic. And so hopefully this gives you some perspective about what life may be like for patients with sickle cell disease outside of the hospital setting. Any final thoughts that you guys have?
I thought it was a great episode, and I really wanted to highlight that the social determinants of health and the psychosocial impact that sickle cell disease has is really, really important to not forget about. And that was one of the last things we highlighted in this episode, but it is critically important that we think about all of those things for these patients.
All right, guys, that wraps up another fantastic episode of the Fellow on Call. Until next time, we'll see you all later.